Joining us now is Sholom Glouberman, whose title I love. Philosopher in Residence. Isn't that great? At the Baycrest Centre for Geriatric Care. He's also the founder and president of the Patients Association of Canada. And before we get to all of that, let me welcome you and let me ask you to go back and just sort of give us some insight into your background, because you worked in the healthcare industry for a while, did you not?
For a very long time,
Yeah.
yes.
What'd you do?
I started at the Royal Victoria Hospital in Montreal, when it was the Royal Victoria Hospital before all the mergers. And I did planning there. And then I went to England and I worked at a place called the King's Fund. So the NHS was our playground. And then I came back to Canada and worked at Baycrest, and then became head of Judith Maxwell's health network on the Canadian Policy Research Network. So
At what point in all of this did you then find out about the healthcare system, not as a doer or practitioner or worker, but as a patient?
Well, I think that my first insight into it was when my father was dying, which is well before any of this. And you see how people behave and how they act in the system. And I became fascinated by it. I wrote a book about people who work in the system and what the system does to them, and became very interested in that. But I never experienced it for myself until well after all of that. I mean, that was 5 years ago, yeah.
And what happened?
It turns out that I had a precancerous growth in my colon that couldn't be taken out with a colonoscopy. I needed to have an operation, and they took out part of my large intestine.
How'd you enjoy that, Sholom?
It was from the beginning no pleasure. It was really interesting to see how I changed, how my attitudes changed, how the system worked from the inside, seeing how you become passive and less proactive, as it were, and also watching how the system distances itself from you, especially if things go wrong.
Did something go wrong in your case?
Oh yes, I got septicemia and had to come back to the hospital. They dealt with the septicemia beautifully, but they denied that its source had anything to do with anybody. It was just a kind of accident.
It was fated to be.
That's right.
You didn't catch it in the hospital or anything like that?
No, it had nothing to do with that.
Now, it's interesting how you say the medical system tends to want to distance itself from whatever happens to the patient, which of course is completely antithetical to what you think doctors and the healthcare system is designed to do, which is to immerse themselves in you to ensure that you get healthy. You didn't pick that up, eh?
Well, let's be fair. When I got the septicemia and when I came back into hospital, they treated it extraordinarily well. So they're really good at it. They're really good at responding to an acute condition. Within minutes after I got into the hospital, I was brought into the investigative radiology lab, where they went and took out the bad blood that was in me and began to treat me immediately. So they're very good at the acute episodes. What they're not so good at is the episodes that are less than acute, less than emergency. So it's following up and making sure that you're healthy, getting healthy, watching you while you heal. They're not that good at that.
Septicemia being, what is that? It's an infection of the blood?
It's an infection. It's an infection of the blood that's caused by bad fluids getting into the system.
You sound like you need a little health care right now,
Yes,
Sholom.
I
You got
do.
a bad throat, don't you?
A little bit of a bad throat.
Okay, we'll
but
just
not
let
too
everybody
bad.
know that.
Yeah.
Okay, so you went through this, very unpleasant circumstance, and that led you, I guess, somewhere down the road to found this Patients Association. What's that all about?
Well, what's happening now is that there's been a huge change. There's a kind of a sea change in the burden of illness. It used to be that people got sick of acute conditions, of infectious diseases, influenza and cholera and smallpox. But now most people who are ill, the burden of morbidity, as they call it, is in chronic diseases. And the system is structured to deal with acute. So you have a kind of misplaced system. And when you have chronic diseases, you need patient participation. Patients have to be part of the system, part of what goes on. And so the Patients Association really, I think, is a response to that. It's to try to organize people, to give them a voice, to make them stronger in being able to speak to the system, and to say what their perspective is on things that are going on.
Nobody speaks to systems, though. You have to
That's
speak.
true.
You have to speak to people. So
Yes.
when you say we need to speak to the system, who do you mean?
The way I say that is that there are three parts of the system that you could talk about. One level is the clinical level. It's when you're actually talking to your doctor and being stronger, being able to do that better. And what are the ways in which you can do that better? The other way is in planning services. A lot of services need patient input for planning to understand what that is. So that's the service delivery level. And the other level is the policy level. What are the policies that we want in the healthcare system? Well, everybody makes policies except patients. So we think that patients should be there and be part of the policy-making process.
But the policy making is done at the cabinet table. Patients are not going to be there.
Well, patients are going to be at policy levels in hospital. They're going to be talking to the minister, and very often the minister has councils that don't include patients because they tend to listen to the various establishment forces like the medical associations and the hospital associations, and now we have a patient group that can also begin to speak for patients.
That patient-centered care is it's the latest flavor of the month, right?
Yes.
How do you take that from something that everybody pays lip service to a real thing?
Well, I think that that's one of the reasons you have to have an organization like ours. It's that you want to turn it into something real and make it meaningful, that it comes on as a flavor of the month every few years. This isn't the first time. So making it real and making sure that patients do have a voice is part of what we're doing. And in fact, the opportunities are there. So everybody is saying, let's do patient-centered care. And I'm saying, here we are, we're the patients. The first thing that we did that was a big thing was that there was an actual conference by the Canadian Institute of Health Research that was called, a meeting on patient-centered primary care. And they had a conference that went on for 2 days, and there were no patients involved in it at all, right?
No patients at the conference at all?
Well, they had 3 patients at the beginning who were telling their stories. They were kind of specimens. But no patients were involved in the discussion. And so we got a table and a room in that meeting to start to speak from the patient perspective, and just pointed out that the very way that conference was organized seemed to require that we have a patient organization that could speak for patients in these kind of circumstances.
I bet they loved you bringing that to their attention. No, they probably didn't. But if you're successful, how will healthcare in this province, how will it manifestly be better?
Well, I think that a whole bunch of things can be better. I'll give you an example. Maybe that's the best way to start. Emergency rooms are organized with the triage nurse at the front desk. The triage nurse is usually a really experienced nurse who really understands what an emergency room is like. And she's excellent at making sure that the people who get into the back are the people who should be there and that they don't really worry the doctors too much. What she's not trained for, or he is not trained for usually, is dealing with patient anxiety. If patients got onto the service delivery planning part, then they would make sure that everybody who sat at the front desk of a hospital could deal with patients and deal with their anxieties, deal with the difficulties that they have, as well as sort of protecting the back of the house.
So they need more than just medical training, they need some
customer
service is
training.
exactly the way I was going to put it.
Yeah.
Okay. Let me return to this dichotomy that you pointed out earlier of acute versus chronic. Because my hunch is you're right. We got a system right now where you come in with a broken arm. They're really good at fixing broken arms and this kind of stuff. But we got a lot of people, I guess, with massive chronic illnesses who are going to be in hospital, I guess in some cases for the rest of their lives, who ought not to be there. Yes. Now that's a massive transition to move the system from dealing with acute and more appropriately dealing with chronic.
We can look at systems that are different. Our system isn't the only one, so we really can compare it. The system that's organized, what you can find is that the systems that are oriented towards the acute are the most expensive systems, and systems that deal better with the chronic tend to be less expensive. And that's a good example of that is the British system, which has a lot more community care than we do. And the most expensive system, of course, is the American system, which has very, very little chronic care. Everything is oriented around acute and specialties. So the question is, how do you shift that way? Well, you can. It's not rocket science.
But it's turning the Titanic.
It's turning the Titanic.
It'll take decades, won't
it? It'll take decades. And one of the things that you need inside that is the patient voice. Because if the patients come with chronic conditions and have a voice and sort of say the kinds of things that they need, what you do is you enable them to take care of themselves better. You enable the system to deal with these chronic conditions better. And it ends up costing less than it would if you just keep on staying in the same direction and providing, because the system deals with the acute episodes of chronic diseases, right? So you have to wait until you're really sick before you get treated, and then it doesn't follow up. What you want is a system that will prevent a lot of these acute episodes, that will be much more companionable, if you like, and follow people in the journey of their condition, rather than only deal with the acute.
Now again, my hunch is 30 years ago, what you are saying would have been considered revolutionary.
Yes.
Today, it's conventional wisdom. Everybody believes this.
Yes.
Is it happening, though?
It's beginning to. I think that this move to patient-centered care and the move to start to people really want us. They want a patients association on the side of the provider as well. So our first partner was the Ontario Medical Association, where we set out the thing called the Patients' Choice Awards, where patients nominated and patients were the jury that selected doctors who were especially especially patient-friendly. Well, that wouldn't have happened 30 years ago, and now it's opening up. And I think that hospitals want to have patients and the patient perspective in what they do.
Well, let me challenge you on that because, you know, and admittedly...
They say they want to.
Yeah, well, that's exactly what I was
Yeah.
going to get to. There's a great deal of lip service paid today to, you know,
Yeah.
the stakeholders being open to hearing from the patient. But, I mean, you and I both know tons of people in there who are still practicing paternalistic medicine, and they don't want to know from the patient. And when a patient starts to advocate too much for themselves, you know, they don't like it. So how do you turn that around?
It's changing. I think that the younger doctors are more open to this. I think that young doctors recognize that the patient has to be involved in chronic care. I think that that's beginning to happen. I think that the illusion that's still there is that specialty training is more important than primary care training. And that whole thing has to be worked on, but that has to be worked on at medical school level.
Financial incentives are all towards specializing, not to being a GP.
Sure, I think, and those things can be changed.
Well, how is that going to, that's not going to change.
Oh, over time, I think it will. I think that what's going to happen over time is that you're going to have a whole new breed of primary care doctors who are going to figure out how to use the system better and have a reasonably good life, and at the same time be able to take care of chronic patients.
But if you can make $200,000 a year being a GP and you can make $1 million a year being a cardiologist, everyone's going to want to be a cardiologist.
I think that it's an illusion that cardiologists make $1 million a year.
Well, I'm pulling the numbers, you know, I'm pulling the numbers a bit out of thin air.
You're talking
there,
about the difference between 200,000 and 350,000 kind of thing, which is a big difference.
Okay.
But I think that the system is going to start to have less place for cardiologists and more room for, well, it's going to be more community cardiologists, which is what they're becoming now.
Community cardiologists.
Yeah, that cardiologists aren't sitting in the hospital anymore, that they're taking care of patients with chronic conditions, they're trying to see them and being the expert support for these things. That's going to be the shift too. I think that it's happening in a way. I think that it's happening slowly, as you say. And I think that there'll be resistance, especially from the more established older guys, and from a lot of the big acute care hospitals that want to maintain their budgets and do everything. But I think that that the shift is happening, and people have to watch and see it. And I think as patients become stronger and begin to have a voice, they'll push the move a little bit more, just a little bit more.
Let me follow up on that last bit, because when you go to the hospital, I think it's fair to say you are never more vulnerable. You are scared oftentimes. You are being poked and prodded with needles and people coming in and reading charts. And, you know, it's really hard to advocate for yourself and be a strong champion for your own treatment when you have no idea what the hell's going on, right?
Absolutely. Yes.
So what do you do?
Well, you give up. And when you're in the hospital and you have an acute condition, you really get out of the way and let them do what they have to do. I mean, when I came in with septicemia, I didn't know what to do. They knew what to do, and I completely give up. I mean, that's it. You're not going to be involved. It's at the other times in the hospital where you can have a stronger voice, not at the moment when the acute condition manifests.
That's the distinction I want to understand, because there is a point at which you simply have to put yourself in their care and say, do what you got to do.
Absolutely.
When are the circumstances under which you really have to be the champion for your own care?
I think that as you begin to heal more and more, you do that. And in fact, what's happened now is that because people can't care for themselves in hospital, everybody is encouraged to bring somebody with them and to have a companion when they're in hospital. I wouldn't go into hospital all alone anymore.
You have to bring somebody with you.
You bring somebody with you.
To champion your care.
Yeah.
One last thing. The Premier is fond of using this statistic nowadays, which is if we don't get a handle on health costs, 80% of the provincial budget, it's less than 50 now, nudging up to 50, but 80% of the budget within 20 years is going to be healthcare. It's going to crowd everything else out. Do you believe that?
No, I think that that's one of the things that is always said. Look, it depends where you start your count from. So there was a big drop in the expenditure on healthcare in the 90s and in the early beginning of this decade. But if you look at the long-term thing, it's still well within our means to spend what we do on healthcare. That's one thing. The other thing, I think, is that the system is shifting. And I think that what this will do is encourage the system to shift as well. That there isn't money means that we have to change the way we do things. We just must. And the easiest way, and everybody understands that shift of morbidity from acute to chronic. Well, that's the way we have to go. And the question is, how do we do it? What are the forces that are necessary in order to do it? And how do we play it out? I think we'll do it.
It is interesting.
I'm slightly pessimistic, but somewhat optimistic too.
Well, you work at Baycrest. You've got to be a bit of an optimist, don't you?
Yeah.
It is true that the financial imperative often brings reform faster than reformers bring reform.
Yeah.
It is true.
Yeah.
Sholom, it's good of you to visit us at TVO tonight. Thanks so much.
It's a pleasure. Thank you very much.